know that majority of you are pretty busy with all the control activities in your districts, especially in Calicut. So basically, the clinical care aspect of our discussion today is probably limited to the patients admitted in Calicut. The other aspect are districts very important. Like yesterday, a healthcare worker got infected from one of the private hospitals in Calicut. Like that. So history is repeating, right? So we don't want that to happen. We are having sort of a clustering of cases in Calicut. So regarding Nipah, നമ്മുടെ clinical care and infection control practices തമ്മിൽ തുലനം ചെയ്യുമ്പോൾ most important aspect is going to be the infection control practices that we need to be adopting in our hospital settings. For example, suppose a suspect case of Nipah lands in our hospital, may it be in Kollam or Trivandrum. Like it can happen. Like means a train at the means a suspect case of we should ensure that there should not be any high risk exposure occurring to any of the healthcare workers in our setting. For that, we have to be prepared not only during this time. I think in Kerala, means whenever we are seeing patients with ARDS or encephalitis, we should ensure that all the personal protective equipment, PPE kit the masking should be there, as well as the hand hygiene has to be there. So whatever we are discussing today is not limited to the next 1.5 months, where I know that every one of us will be very careful. It applies to the rest of our career, because Nipah outbreak can occur at any time in Kerala. That is what we have been. That's our experience over the last 4 years, and we don't want any healthcare worker to be caught off guard. Means that whenever we are seeing patients with typical pneumonia, acute respiratory distress syndrome, especially youngsters, encephalitis and all, our health is in our hands. So with that, I'll go to a brief introduction. We know that this Nipah virus was first recognized in 1998-99 time in Malaysia as well as Singapore. So 276 reported cases. At that time, there was an intermediate host was involved. From the bats, the bat-eaten foods were eaten by the pigs. Pigs got infected, and from the pigs in the farm, the humans got infected. And it was the infections were predominantly the encephalitic type. That is why the mortality there was not very high compared to what happened in Bangladesh and what happened in Kerala. And India, we have seen around 5 outbreaks in 2001 in Siliguri, 2007 in Nadia. So these two areas are in close proximity to the Nipah belt in Bangladesh. So it was sort of a contagious spread. You can see that from Malaysia it spread to Singapore, and then Bangladesh Nipah belt it spread to the the neighboring districts of Siliguri and Nadia in West Bengal. So during the Siliguri outbreak, the human-to-human transmission was established. So during the Malaysian or Singapore outbreak, human-to-human transmission of Nipah virus was not established. It was basically from pigs, from the bat to the pigs, and from the pigs to the human beings. It was basically an encephalitic sort of presentation without human-to-human transmission. Whereas in Siliguri, the human-to-human transmission was established. And the basic difference is that there is a difference in the genotype of the virus leading to the Nipah infection in Malaysia and Singapore, which is clade 2, now referred to as NIV-M. And the Bangladesh and the West Bengal strains belong to the Bangladesh. It is a clade 1, NIV-B. And then in Kerala, we had this outbreak in Calicut in 2018. Then we had one case in Ernakulam in 2019, one case in Calicut in 2021, and now we are experiencing sort of a 2018-like scenario where there is a clustering. Now, the genotype responsible for Nipah virus infection in Kerala is very close to the Bangladesh genotype, but it is not NIV-B. It is actually NIV-I. They say that there are certain distinct differences between the genotype or the genotype signature of the Bangladesh strain compared to the strain isolated from the bats as well as humans during from the Kerala outbreaks. So that is now termed as NIV-I. That is an Indian genotype. Now, the natural reservoir is actually the large fruit bats. As a Pteropus medius as a large fruit bat, which is locally referred to as the Asian flying fox. The usual insectivorous bats are not taken as the reservoirs of Nipah virus. So the circumstantial evidence of human-to-human transmission of Nipah virus was detected during the Siliguri outbreak in 2001, where 33 healthcare workers and hospital visitors became ill. And we know that the Nipah infection tends to occur as a cluster or as an outbreak. So in priority pathogens like hand raise Sandhya Mohan. Okay. I think probably by mistake. So in priority diseases like Nipah, even one case is taken as an outbreak. So usually we say that more than one case is an outbreak, but for infections like Nipah, even one case can be considered as an outbreak. Now coming to the epidemiology, we know NIV, Nipah virus, is a highly pathogenic paramyxovirus. Viruses because of immune tolerance mechanisms that basically means that the Nipah virus won't lead to symptoms in bats. Whereas the pigs and all the mammals can get infected with the Nipah virus because of the fact that this Ephren B2, that is in COVID, we used to say that the human receptor in the endothelial cell is the ACE2, like that the receptor to which the Nipah virus is supposed to bind to is actually Ephren B2 and B3, which is actually preserved in almost all the mammalian species. So all the mammals theoretically can get infected, but the birds don't have this Ephren B2, and so they are not going to get infected. And important, sir, during the Calicut time, there was a hoax like if you eat the chicken, you can get infected. So how we should counter that this false story is that the chicken and other birds are not mammals. So they don't have this Ephren B2. So the birds can never be infected with Nipah virus infection. Bats are mammals, like that. Okay. So the pigs are the amplifier host, which was described during the Malaysian outbreak. Till now in Kerala, we have not identified virus in any other animals other than any other mammals other than the Pteropus, the medius bats. Okay. Now coming to this is a very controversial thing, the seasonality. The seasonality was strongly implicated in Nipah outbreaks in Bangladesh as well as India. So all the outbreaks occurred during the months of winter to spring. That is, we used to say it is from December to May. That is during the breeding season of bats. So that was the conventional wisdom that we got. So bats, because of immune tolerance, there will be the virus in bats. But during periods of stress, so usually during the breeding period or the birthing cycles and all, there will be periods of stress. During this period, there will be increased secretion of virus in the various secretions, the urogenital secretion, genital fluids, the saliva, urine, feces of bats. So that we used to say it is from the December to May. Now we have had two cases in the last year as well as this year, it is in September. So probably we'll have to keep an eye open for, it's not only during December to May that the spillover from the bats can occur to humans. All the year around, probably we need to keep a watch on this. Incubation period is between 4 to 21 days, and during the Coricat outbreak, the average incubation period is 10 days. This is important. So this is the reason why all the contacts are kept in isolation for 21 days. That is the longest period of incubation. Now coming to the Nipah virus dynamics in bats. Okay, so the outbreaks in the Pteropus bats, bats live in the bat roost may contain millions of birds, right? So this is driven by increased population density, loss of immunity over time, and viral recrudescence resulting in multi-year interepisodic periods. That is, even in bats, there is a potential of having this multi-year interepisodic periods where this viral shedding can occur. So increased population density, we all know, that is when the number of bats in the roost increases, there is always a chance of spillover occurring. Loss of immunity over time, that means that usually the bats will have this neutralizing IgG antibodies. And after some point of time, there is a decrease in immunity, which occurs during periods of stress, like the birthing period, periods of mating and all those stuff, or when their habitat is threatened and all. So at that time, the T cell mediated immunity will come down, and there is a chance of increased viral replication occurring in bats. And the viral recrudescence. Recrudescence means that the same thing, the virus might become apparent in the secretions. So theoretically, the bats can shed virus at any time of the year, highlighting the importance of routes of transmission to the timing and location of human Nipah virus outbreaks. Why I am stressing on this aspect is, usually all our control activities previously were focused on this December to May period. So now with our experience over the last 3 years, having index case coming in September, August period, probably we have to give importance to this slide saying that this shedding and this spillover can occur during any point of time. Means that always we need to be on alert for the spillover events occurring in the state of Kerala. Now, coming to the pathogenesis, we know it is a para-myxovirus infection, and the mode of transmission is basically by the inhalation of the droplets. It's not basically an airborne infection. It's not an airborne infection like, say, chickenpox or measles or to an extent COVID-19. It is a droplet mediated transmission, as well as while coming into contact with the secretions of the patients. And from there, it goes to the respiratory epithelium, and from there it is disseminated to other lymphoid organs, to the brain, the kidney, as well as the spleen, and resulting in a necrotizing encephalitis as well as necrotizing pneumonia. So that is how the patients are going to manifest with pneumonia as well as encephalitis. Now, coming to one important aspect, there's a transmission or the modes of transmission of Nipah virus. So this can occur. So all these things we all know. Direct contact with infected bats or direct contact with the infected pigs or from other Nipah virus infected people. Then that is the mechanism in Kerala. It is actually direct contact with the bat that we have never established in how the index case got infected. We have speculations, theories, hypotheses, and all, but we have not established how this spillover occurred. When the rest of the cases occur because of human-to-human transmission in hospital settings and in family clusters. The indirect contact is actually by bringing the date palm sap. Is the postulated mechanism in Bangladesh, and through horse meat in Philippines. So in recent outbreak, the direct spread from index patient to others by contact and droplet spread. So that's probably what would have happened. So the index case was symptomatic from 24th of last month. The respiratory symptoms, was admitted and died on the 30th. So the first patient presenting with ARDS, and the diagnosis entertained was communicated pneumonia with ARDS and type 1 respiratory failure. So probably should we suspect Nipah in such a patient is very, very difficult to say. Suppose if the patient had this the neurological manifestations as well, that is the respiratory plus neurological manifestations, then in Kerala we should definitely suspect Nipah virus infection. But suppose the clustering occurs, that is someone dies in the family and then the other members are getting infected. They are also having this respiratory program followed by neurological features. Definitely we should not miss out on Nipah virus infection. Now, coming to the transmission of the Nipah virus based on investigations, this is actually 14 years of investigations in Bangladesh. It was published in NEGM. So this is basically the transmission dynamics. So we know that all patients won't transmit Nipah virus infection to others. We know that. We have this super spreading happening during the 2018 Kozhikode, the index patient, the Sabit, actually from him, the 17 others got infected, right? But no, the transmission from other patients to other patients were not to the same extent as the index patient. So this is very important. Some patients are some patients happen to be super spreaders in Nipah virus infection. So you can see that we are all familiar with R0. R0 means that COVID, if the R0 is one patient can infect another patient, right? So that is why how we used to calculate R0. Actually, if the R0 is less than 1, actually the epidemic cannot propagate itself. It will have a natural death sort of thing will happen. Okay, the R0 is 1. From one person, the transmission will occur to another person, like that. If R0 is 2, one infected patient can infect 2 others. So in this scenario, the R0 of actually Nipah, based on the observation studies done in Bangladesh, is actually 0.33. That is, one infected patient will be able to infect, say, around 0.3%. And the more severe the infection, the more chance of transmission to others. You can see that this is actually plotting the reproduction number as R0 among patients with breathing difficulty. So those with breathing difficulty, the R0, that is actually around 1 or hovering around 1.1. Means that if the patient is sick, the patient is having a respiratory involvement, patient is having ARDS, the chance of that patient spreading the infection to others is going to be very high. That is very important. So that is one very good advantage with regard to Nipah virus infection. We know that COVID, influenza, etc., chickenpox and all, there is a chance of a pre-symptomatic or an asymptomatic transmission. So that is not there based on the available evidence with Nipah. Nipah, only the really sick patients are going to transmit to others. Those with mild symptoms are unlikely to transmit. There is no pre-symptomatic or asymptomatic transmission occurring with Nipah. So what we observed is that usually there will be a prodrome of around say 3 to 4 days, and a patient will be having high-grade fever. At that point of time, it will be very difficult to differentiate Nipah from other infections like say flu or dengue and all. By day 4 and all, the respiratory symptoms will predominate. Patient might develop dyspnea, and by day 5, the patient will develop seizures. And that is going to be the red flag sign for us. That's when the patient develops seizures and all. So usually the patient is going to become infective when the patient is going to develop the respiratory symptoms. That is by around say day 4 or 5. So that is actually an a window of opportunity to control Nipah virus infection. Suppose Nipah, the transmission dynamics is like say COVID or flu, then there is not much we can do, because now even asymptomatic infection, angana transmit it becomes a huge issue. But unfortunately, Nipah doesn't spread like that. So that is the importance of this slide. So those with breathing difficulty, the chance of them transmitting to others is very high. That is, they are the people who are likely to end up as super spreaders. Okay. Then another aspect is with regard to the age of the patient. So that is, as the age is going up, the chance of them becoming super spreaders is more. So you can interpret this in another way. As the age is going up, okay. So as the age is going up, the patient developing a severe infection is also likely to be higher. Such patients are likely to end up as super spreaders. Okay. So this is basically, a network analysis sort of thing. You can see that, this is the primary case is actually the red circle, the blue circle. So blue circle, more than 25-year-old with breathing difficulty, and the green one is less than 25-year without breathing difficulty. You can see that all the transmission chains or secondary transmission did occur in patients with dyspnea. So this is very, very important. നമ്മളൊരു ഹോസ്പിറ്റലിലാണെങ്കിലും കൺട്രോൾ ആക്ടിവിറ്റീസിൽ ഇത് വളരെ വളരെ ഇമ്പോർട്ടന്റ് ആണ്. ഞാൻ കാലിക്കറ്റിന്റെ കാര്യത്തിലല്ല ഇത് പറയുന്നത്, കാരണം കാലിക്കറ്റില് വി ആർ ഹാവിംഗ് a very good contact tracing mechanism. We know the high risk contacts, the low risk contacts, etc. Other hospitals also, ഇതേപോലെ തന്നെ out of the blue, someone is presenting as ARDS and later on, suppose that they turn out to be Nipah, അവിടെ ഒരു ട്രാൻസ്മിഷൻ വരാതിരിക്കണം. അതായത് സിക്കായിട്ട് വരുന്ന പേഷ്യൻസ് എല്ലാം തന്നെ. So when we are actually handling those patients, minimum we should be having a mask as well as the hand hygiene or the gloves sort of thing. So അതിനു വേണ്ടി മാത്രമാണ് ഈ സ്ലൈഡ് നമ്മൾ കാണിച്ചതാണ്. ഒരു proven Nipah patient deal ചെയ്യാൻ വേണ്ടിയുള്ള infection control mechanisms ഒക്കെ we are all thorough with that. There is no question about that. പക്ഷേ ഈ proven Nipah ആകുന്ന വരെ എപ്പോഴും ഒരു threat നമുക്കുണ്ട്. At any point of time, so any hospital can have an ARDS sort of patient without any link. ആ ഒരു പേഷ്യന്റ് പിന്നെ Nipah ആയിട്ട് മാറുമ്പോഴേക്കും the chance of us getting infected is going to be high, right? So we want to avoid such scenarios. So whenever we are dealing with these sort of patients in any district, okay, patients with ARDS, with pneumonia, basic thing, the respiratory protection we need to have, as well as we need to stick on to the basics of hand hygiene. Okay. And the number of secondary cases per case patient is based on the Bangladesh data is highly over dispersed. 5% of case patients accounted for 86% of the transmission events. A total of 9% of case patients transmitted Nipah to others. Basically, in Nipah clusters, what is observed is that from 91% of the patients, secondary transmission did not occur. So actually, secondary transmission occurs from the 9% of patients. Of this also, the 5% of the cases accounts for 86% of transmission events. അതുകൊണ്ടാണ് ഇതിന്റെ ഇമ്പോർട്ടൻസ് വരുന്നത്. അതായത് സൂപ്പർ സ്പ്രെഡിംഗ് ആണ് what is happening in Nipah. The clusters are occurring because of super spreading events are occurring. ഈ സൂപ്പർ സ്പ്രെഡർ എന്ന് പറയുന്നത് ഒരു ആളുടെ പേഴ്സണൽ ക്യാരക്ടറിസ്റ്റിക്സ് മാത്രമല്ല. അത് നമ്മൾ പറഞ്ഞു, ചിലപ്പോൾ ഏജ് കൂടുമ്പോഴായിരിക്കാം. Immunosuppressed patients may be having more viral load, and patients developing ARDS or respiratory symptoms are likely to transmit to others. This is one thing, that is the patient factors. There are other factors. A patient admitted in the ICU, we may be doing a lot of procedures like the suctioning might be there, intubations. All these things are aerosol generating procedures. That in such scenario also super spreading events are likely to occur. Then the patient is taken through very narrow corridors without aeration and all. Other environmental factor which might promote a super spreading event. So these sort of things we need to keep in mind. അല്ലാതെ എല്ലാ പേഷ്യന്റിൽ നിന്നും ഇങ്ങനെ ക്ലസ്റ്ററിംഗ് ഉണ്ടായിക്കൊണ്ടിരിക്കുന്ന ഒരു ഡിസീസ് അല്ല Nipah. Now, predictors for acquiring infection. So the most important predictor while acquiring infection is actually the hours of exposure. You can see that when the with the patient, if the hours of exposure are more, the chance of us getting the infection is also likely to be higher. Okay. And also the exposure to the body fluids. If you're having exposure to the body fluids without protection. So these are the two factors which might lead to infection in the caregivers. So two things. One is actually the the hours of exposure. The family member spouse are infected. And the reason this hours of exposure ആണ്. The second is actually contact with the body fluids. So in our hospital settings, our aim must be to become, the triad of epidemiological triad means, epidemiological triad means that there has to be an agent, host, and environment. Okay. So if there is an agent, host, and environment, any infection can occur. So if you take the case of Nipah, so agent is probably there. Okay. The environment is conducive, and then host. So whether we should become a susceptible host or a non-susceptible host is in our hands. So Nipah virus infect chance through respiratory secretions or other secretions. If you are using the mask properly and if you are using hand hygiene properly, the chance of us getting infected is almost zero. Calicut patient patients the chance of us getting infected is going to be zero if we decide that we are going to be a non-susceptible host by using our mask properly and using the 5 movements of hand hygiene properly. Now, coming to the clinical features, I said that it's not much different from any of the other tropical fever syndromes circulating here. Patient will be having fever, weakness, headache, respiratory distress, cough, vomiting, muscle pain, all these things. Most important thing is on day up to day 4 or so, patient will be having features of fever, headache, myalgia, excessive fatigability, and all those stuff, right? Then patient will have and cough and all. Then the patient will have the respiratory distress, and by day 5, patient is likely to go into altered mental status and sometimes seizures and all. Okay, and can present as a pulmonary neurological syndrome. That is basically pneumonia with necrotizing encephalitis, or patient can have a flu-like syndrome with just involvement of the brain. That is flu-like syndrome with encephalitic presentation. So these are the two presentations that we have observed in Kerala. So this is actually from the the outbreak investigation done during the 2018 Calicut. So the male female division and all. Males and females exposed the chance of getting infection is actually the same. And you can see that around 84% of the cases during the Calicut outbreak had this primary neurological involvement. Primary neurological means respiratory with neurological. And around 11% had just respiratory symptoms. And 5% had only prodromal symptoms. And literature says that, in around 11% you can have asymptomatic Nipah as well. So we need not be worried about that, because from asymptomatic patients, the chance of transmission is almost zero. Now, the complication profile observed in Kerala till now, encephalitis plus ARDS. Okay, you can see that more than 50% had encephalitis plus ARDS, encephalitis plus ARDS plus myocarditis. So there was one question why, the mortality during in Kerala was very high, 2018. The reason was that the myocarditis along with ARDS was never, described for Nipah. During Bangladesh outbreak also, the myocarditis was not really mentioned. So in more than 50% of the patients with encephalitis had ARDS plus myocarditis. We know that ARDS plus myocarditis is going to be a death sentence. Okay. Now this is the complication profile. The only thing we need to keep in mind is that you can have the flu-like infection plus encephalitis presentation, or a pneumonia plus encephalitis sort of presentation, or you can have just a flu-like presentation, or some patients can be asymptomatic as well. Now coming to the days of fever at the time of presentation. So majority of the patients were diagnosed when they developed this altered sensorium. So you can see that is the reason why the majority of the patients were diagnosed on day 4 or day 5. One like a diagnosis in the contact test. So now we have around 78 high-risk contacts in Calicut who are isolated. One of them developing a fever, and they are actually asked to report the symptoms. We are also proactively reaching out to them twice a day to see whether they are developing any symptoms. Day 1 diagnosis. Allata natural course around day 4 or 5 only we will be able to have other features which might lead us to suspect Nipah virus infection. So this is actually day from So this is when actually the deaths occurred. You can see that majority of the patients died by around, you can see the 5th or 6th day or 7th day. There is no, by 5th day they are developing this encephalitis, and in around say 48 hours they are dying. That's what we observed during 2018. So that is a day from admission to death. Majority of the patients died within say 48 to 72 hours. Now, once they develop encephalitis, ARDS, and myocarditis, we could not do much during 2018 because we never had access to the monoclonal antibody and all. Okay, so this is actually the symptom profile. All the patients had fever, headache in 94%, fatigability 94, cough, sore throat, you can see, vomiting, diarrhea, breathlessness in 78%, alteration of sensorium in 84%, seizures in 36%. So this is a very confusing thing because literature says that, the seizures is there in less than 10%, whereas we observed in 36% during the 2018 outbreak, whereas myoclonus is supposed to be sort of pathognomonic, a clue which might help us in suspecting Nipah. Encephalitis with myoclonus, we need to think about Nipah as well, especially diaphragmatic myoclonus, which is seen in 10%. Literature myoclonus is seen around say 40% and seizures less than 10. We know that patients when they are sick, probably this myoclonus and seizures might history nalle seizure so there might be seizures. And another important clue is dysautonomia. So vasomotor dysautonomia means that when there is an increase in intracranial pressure, like when what is occurring in encephalitis, we are expecting the heart rate to come down, bradycardia. Sometimes that won't happen. Patient will be having the fluctuations of BP. Along with that, patient may be having features of raised ICP with tachycardia. That's any vasomotor dysautonomia. So patients with encephalitis with vasomotor dysautonomia, we need to think about Nipah virus infection also. Presence of neurological deficit and bilateral ptosis and ophthalmoplegia. Means 2018 hallmark presentations like vasomotor dysautonomia, myoclonus, bilateral ptosis, and ophthalmoplegia. So from this, the take-home message has to be that initial 4 days, from the symptoms alone, it will be very, very difficult to suspect Nipah virus infection unless the patient is a high-risk contact or something like this. Or that means that patients with epidemiology link we can suspect. Otherwise, in the first 4 days, it's very, very difficult. From the day 4 onwards, patient will develop dyspnea or ARDS. Then also, we will think that it's likely to be influenza or COVID-19, which is much, much commoner than Nipah. But by day 5 or day 6, when the patient is developing this alteration, sensorium, and features of encephalitis, then you need to put everything together, right? The patient is having a prodrome, patient is having respiratory involvement, then patient is having encephalitis. That is when, you need to think about this pulmonary plus neurological syndrome. And any pulmonary plus neurological syndrome in Kerala, we need to have Nipah as one of the differential diagnoses. Now, coming to the lab investigations per se, you can see that it looks like any viral infection. The total count is around say 5,000. This is a mean total count. Okay, is around 5,000 sort of thing with neutrophil predominance. This is viral infection. So viral infection with neutrophil predominance, that is in COVID-19, right? COVID, so the lymphocyte, because T cell apoptosis was there, and because of that, lymphocytopenia was there. Like that, in Nipah also, what we observed during 2018 is that this is basically a polymorph predominant infection. There is a mild thrombocytopenia. Dengue, 50,000 out on the both. It is a mild thrombocytopenia. And one thing that we observed during 2018 is epidemiology link but dengue differentiate and symptomatology difficult. But when we are entertaining diagnosis like say leptospirosis or strep typhus or dengue, you can see that the transaminases level will be a bit higher, right? So almost all the viral infections and multi-system bacterial infections like leptospira, definitely the SGPT will be say around hundreds or less than 200 like that. But what we observed in Nipah is just slightly elevated, but no, the mean was around say 40, 50 like that. Once the patient goes into hypertension, this will change. But prior to that, E range okay. And the patient had acute kidney injury only towards the end. There is no when the patient become terminally ill only, they had acute kidney injury. But mind you, apart from the lung and the brain, other areas where the viral replication actively goes on are the spleen as well as the kidney. Okay. Now coming to the definition. So what is a suspected Nipah case? Person from an area or locality affected by Nipah virus outbreak who has features of fever with new onset altered mental status or seizure, or fever with headache, or fever with cough and shortness of breath. So this is important thing in the patient from an area or locality affected by Nipah virus disease. So suppose we are someone from Calicut is presenting to Trivandrum Medical College, saying that from yesterday I'm having fever and sore throat, headache, and all those things. Inger patient Nipah suspect we have to isolate the patient and then we have to send the sample. Calicut Medical College, we can send it to IAV Thonakal. But she is suspect. But this area and locality importance. We cannot take the entire Calicut as an affected area. But every day the government is saying that the containment zones, so we have to make an understanding about from people from which all areas or locality in Calicut should be included under the suspect list. The Calicut in the respiratory symptom isolate the test and baki districts in Illa. Other district also the containment zones in the high risk zones in the list updated based on their contact tracing which is going on there. That's why the casualty triage, casualty hospital contact points OPD anyone who is coming from Calicut, so our triage then we compare with the list that we have with the containment zone definitely red channel vary that person has to be isolated and the sample has to be excuse me minister to call continue. Hello madam. Now coming to that is definition of a suspected Nipah case. Now the probable case. The suspected case patients who resided in the same village where the suspect or confirmed case of Nipah were living during the outbreak period and who died before complete diagnostic specimens could be collected. Okay. For example, the outbreak, the index case 30th death. So a patient samples only when his the kid as well as the brother-in-law got admitted in another hospital with the similar symptoms. So, this first patient is confirmed case really sample collected. So he will be a probable case. Or suspect case patients who came into direct contact with confirmed case patients in a hospital setting during the outbreak period and who died before complete diagnosis. So basically, probable case that they have all the features, clinical features suggesting Nipah virus infection, and they have very strong epidemiology link. But unfortunately, due to some reasons, we were not able to confirm the diagnosis in such patients. The probable case of Nipah virus infection. Now, coming to the confirmed case, it is actually very easy. Suspected cases with lab confirmation are the confirmed case. So, how can we confirm the diagnosis of Nipah? So, what we are doing here is, we know Nipah is a enveloped RNA virus. So, now what we are doing is, we are doing the PCR test from the respiratory secretions, the urine, blood, as well as the cerebrospinal fluid. And during the 2018 Nipah outbreaks, or during all the outbreaks in Kerala, the majority of the cases were identified from the respiratory secretions. When you are sending samples, you are supposed to send the respiratory specimen, the throat swab, nasopharyngeal swab, the CSF, the blood, as well as the urine. Okay. And if you are able to isolate the culture of the virus also, then we will say that it is a confirmed case of Nipah. So confirmed case is either a PCR positive case or a culture positive case. Culture is done only in NIV Pune, but we diagnose PCR. Now coming to the definition of the contact. A close contact is defined as a patient or a person who came in contact with a Nipah case in at least one of the following ways. We all know this. Admitted simultaneously in a hospital ward or shared room with a suspect confirmed case of Nipah, has had a direct close contact with a suspect or a confirmed case of Nipah during the illness, including during transportation, has had direct close contact with a deceased person, means a deceased person in a funeral, during the time of funeral or during the preparation of the body for burial, etc., has touched the blood or body fluids like saliva, urine, vomitus of the suspect or confirmed case of Nipah, has touched the clothes or linen of suspect or a confirmed case of Nipah. So all these contacts should be followed up for appearance of symptoms of Nipah for the longest incubation period, that is 21 days. And in definition of contact, now we have divided into high risk contacts as well as the low risk contact. I think all of you have seen the 2021 September, the revised Nipah guidelines, where now everything is mentioned beautifully. And the longest incubation period is 21 days. All the high risk contacts as well as the low risk contacts should be in isolation for 21 days, and there will be a symptom check daily. And if they are having symptoms, they will be immediately be transported to the hospital for testing. Now, coming to the diagnosis, we all know that it is a BSL-4 pathogen, but an inactivated the virus, we can do the PCR in a BSL-2 facility by taking BSL-3 precautions. So the diagnosis here is depending on depends on a PCR. A PCR positivity is what we are looking for. In the convalescent phase, we have access to the ELISA as well, but now we are relying more on the PCR for making a diagnosis. Now the centers capable of doing the PCR for Nipah in Kerala as of now, one is the Kozhikode microbiology, the virology lab. Then a mobile unit from NIV Pune, I think, as well as from a mobile unit from Rajiv Gandhi is also going there. So these are the testing centers in Calicut. And Institute of Advanced Virology in Thonakkal and NIV Alappuzha can also be are also capable of performing this Nipah testing. Now, coming to the management aspect. So management, we all know that this is one disease, is a priority pathogen for WHO because we don't have an accepted treatment. We don't have an accepted vaccine also. We don't have an effective treatment or an effective vaccine against Nipah as of now. So basic pathophysiology of Nipah is necrotizing vasculitis with predilection, especially for the brain as well as the lung. In 2018 outbreak, myocarditis was also present in 51% of the patients. Fibrinoid necrosis of kidneys also observed. So basically, it is a necrotizing vasculitis affecting the brain and the lung. So treatment measures, basically it is a supportive treatment. And majority of the patients are likely to have this ARDS or this encephalitis. So they require supportive treatment, anticonvulsants, treatment for secondary infection, mechanical ventilation, rehabilitation, nutritional support, the fluid therapy, and all those stuff. So during the Malaysia outbreak, we all know the ribavirin was tried in an open label trial, and it showed around 36% mortality benefit. But then later, in vitro, the hamster model and all, it was not able to bring down the mortality. This ribavirin, even though in an open label trial it was found to be effective, in vitro studies did not show that any benefit for ribavirin. So the mortality rates between different outbreaks are very different. Malaysia 40%, Bangladesh 70%, and came to Kerala more than 80% mortality, probably because of ARDS plus myocarditis. And the mortality very high with the NIV B strain genotype as well as NIV I, that is the Indian genotype, because of increased involvement of the respiratory tract leading to ARDS. And this clearly demonstrates the differences in pathogenicity between the clade 1, that is the Bangladesh variant, and clade 2, that is the Malaysian variant. And we are having the clade, the Indian variant also. So basically, we don't have any known treatment or vaccine available for either people or infected animals. Okay, ribavirin has no. This is what I already mentioned. One study, it's an open label trial, looked at the role of ribavirin in acute Nipah encephalitis in 2001, showed there is a 36% reduction in mortality. But then in vitro studies could not prove that there is a mortality reduction with ribavirin. Hamster model, etc., it was not found to be effective. And this is the publication from Calicut by Chandani Madam, done during the 2018 outbreak. There also, what we observed is that ribavirin therapy was tried, but there was no evidence for its benefit. So we did try ribavirin in all patients during 2018, but then our mortality was around 90%. So from our experience also, ribavirin may not be an effective drug for either for prophylaxis or for treatment. Now coming to the much talked about the monoclonal antibody, that is the M102.4. So this monoclonal antibody was, we got this monoclonal antibody. V means the ICMR, and NIV got this monoclonal antibody from the Queensland University in 2018. By that time, all the cases, the outbreak was under control in Kerala, so we could not use it in any of the patients. 2019 also we did not use because the patient was not was clinically stable. 2021 the patient died before we could use it. And this monoclonal antibody is actually a fully human monoclonal antibody against the G glycoprotein of the Nipah virus infection. So the interesting aspect is that why the Australia Queensland University has this neutralizing antibody where reported. The thing is that whenever we talk of Nipah, we should another infection also should come to our mind. That is the Hendra virus infection, which is affecting the horses in Australia. For that, they came out with this monoclonal antibody. So this Hendra and Nipah are very closely related viruses and infections, and the same monoclonal antibody is found to be effective in the African green monkey models, and this can be used for prophylaxis. Actually, it is recommended for prophylaxis. Can be tried for treatment purpose as well. You can see the now coming to the role of remdesivir. In 2018, we never had access to two drugs, right? Remdesivir and favipiravir were not available in the country. Both the drugs became available only because of the COVID-19. And we know it is a nucleotide analog with broad spectrum activity against the RNA viruses. And for Ebola also, the high dose or remdesivir was tried. And in animal models with African green monkeys, this was found to be very effective. Okay, following the lethal challenge in African green monkeys treated with remdesivir showed that it is a promising antiviral treatment for Nipah virus infection. Now if we are looking at the CDC treatment for Nipah virus, they say that remdesivir has in vitro activity against the Bangladesh strain as well as the Malaysian strain. So remdesivir can be tried on a compassionate basis. Okay. The basic difference between favipiravir was also tried in the hamster model and found to inhibit the replication in the hamster model. The basic difference between favipiravir in vitro studies and remdesivir in vitro studies is that remdesivir is effective against the Bangladesh variant, which is very, very close to our own variant. That is the I variant. Okay. Whereas favipiravir has never been tried in against the Bangladesh variant. It was tried only against the Malaysian variant in vitro. Okay. So this is the study looking at the role of favipiravir. So the first successful treatment of Nipah virus infection in vivo with a small molecule drug suggests that favipiravir should be further evaluated as an antiviral treatment option for Nipah virus infection. The only thing is that favipiravir has never been tried against in vitro against the B variant of Nipah virus infection. Now coming to vaccine, we know that we don't have a human vaccine against Nipah. The trials are going on, but in Australia, they are having a vaccine against the Hendra virus infection. Okay. So based on this viral G glycoprotein, not an important point for us as of now. Now, probably all of you must have seen this treatment algorithm, which was revised in September 2021. So basically, any patient who is a confirmed case of a Nipah virus infection, that is a tested positive case, the treatment options are, we need to continue the intense supportive care, and we can consider for the monoclonal antibody. There is a M102.4, remdesivir, favipiravir, or ribavirin. Because all these things, they have never been tried. We don't have that much evidence in humans. So basically, all the decisions have to be taken by an institutional medical board. So whenever there is an admitted case of Nipah in your institution, immediately form an institutional medical board. And then you can decide on the treatment modalities to be followed, whether to give monoclonal antibody. The dose is clearly given 20 milligram per kilogram as infusion, 2 doses in 48 hours. Then ideally, even if you are giving monoclonal antibody, it has to be combined with remdesivir. There is 200 milligram loading followed by 100 milligram BD for 12 days. For COVID, we used to give for 5 days, whereas all the studies in animals, they had used remdesivir for 12 days. Or if you are using favipiravir, you should be giving 1,800 milligram twice a day, followed by 800 milligram BD for around 13 days. It has to be used. And then the dosage of ribavirin, if you are using ribavirin, this is something that we used during 2018, 2 grams stat, followed by 1 gram 6th hourly for 4 days, followed by 1 milligram 6th hourly for the next 10 days. Now coming to the post-exposure prophylaxis. So post-exposure prophylaxis for all the high-risk contacts. Ideal thing would be giving them monoclonal antibody, but then for all the high-risk contacts, but then no one has adequate quantities of monoclonal antibodies to be used for post-exposure prophylaxis, and that is why the ICMR say that whatever little monoclonal antibody that we might have, we should be using it only for the treatment purpose and not for the prophylaxis. So the patient high-risk contacts for prophylaxis, the options are either remdesivir or favipiravir. These are the two drugs which can be used for the prophylaxis. Now, this is going to be the 2023 the guidelines, which probably might be released today or tomorrow. So the rest of the things are the same. The only thing is that in 2023 there was another article which looked at a higher dose of remdesivir. So the previous 2021 we said that for treatment we should be using 200 milligram loading of remdesivir followed by 100 milligram OD. That is for COVID we are using that. But there is a 2023 article which says that if the patient is having encephalitis and all, we should be going for a higher dose of remdesivir. This, for example, in Ebola patients also remdesivir was tried, but at a higher dose. They gave 225 milligram per day. So probably if the patient is having a Nipah, ARDS or encephalitis, we should be using a higher dose of remdesivir. That's 200 milligram loading followed by 200 milligram per day. That is 100 milligram BD. The patient is having a mild infection only. Some patients are having only mild infection. During this time also, some patients are having only mild symptoms. So for them, the conventional dose of remdesivir is justified. If they go into ARDS or encephalitis, hike to the 100 milligram BD dose. Otherwise, go with the 100 milligram OD dose. Okay. And all this, the monoclonal antibody, etc., should be administered only in a compassionate ground. The post-exposure prophylaxis, the dose of remdesivir remains the same. The two additions in the algorithm is, one is the difference in the dosage of remdesivir for the severe cases, that is those cases with ARDS and encephalitis. Second is the role of immunomodulators. Immunomodulators, by immunomodulators we mean those steroids. Okay. Immunomodulators should be considered in case of a GCS, Glasgow Coma Scale less than 8, less than or equal to 8, rapid neurological deterioration, or cytokine storm grade 3 or 4, or in case of secondary hemophagocytic lymphohistiocytosis. What actually COVID did teach us, something that we already knew with respect to dengue as well as leptospirosis. Most often the adverse events occur due to exaggerated immune response, or what you term as the cytokine storm. So in Nipah as well as Ebola also, this has been described. There is no exaggerated cytokine storm. So if that is occurring, it is better to treat the patient with immunomodulators. Now, coming to the discharge policy, or whenever a patient is admitted, definitely we know that we admitted in an isolation facility, and all the healthcare workers should be using and the proper PPE and all those things. And when are we going to discharge the patient? So patient is clinically fine, symptoms are okay, hemodynamically stable. The 3 samples, that is 3 samples means, we are supposed to send the throat swab, the urine, the blood together, right? CSF, if we are taking CSF, we can send that. Okay. Anyway, when we are contemplating discharge, we won't be looking at the CSF sample. So the 3 samples should be negative on 2 occasions, which are 5 days apart. That is the discharge criteria. Now, the next aspect is a patient is in isolation. Okay. Either means Calicut in the high risk area means containment zone in the he's saying that he's having influenza-like illness like symptoms, and we have put the patient in isolation. We have sent the sample, and when are we going to discharge such a patient? So if the patient is asymptomatic, then the test is negative, we can discharge the patient. Okay. But if the patient is continuing to be symptomatic, epidemiological link under test negative, but he is continuing to have symptoms, then we need to repeat the test after 2 days. Okay, so means frequency can be decreased, because now if we are having available access to labs and all, we can do that. But at least we need to repeat the test after 2 days if the symptoms are really persisting. Negative anengil. So symptoms are persisting, you are suspecting Nipah, there is an epidemiological link, but 2 tests are negative. Then actually we can go for repeat testing. Patient repeat test during this period of time we should have arrived at a diagnosis. This is the discharge guidelines. Okay. So basically, criteria for discharge of patient from isolation facility was person with suspected Nipah and tested negative. So tested negative and totally symptom-free can be discharged with observation at home for a total of 21 days. The epidemiological link ulla patient karyana. Tested negative and continue to have fever and other symptoms need a 2 days to exclude Nipah virus infection. Okay. No need of repeat testing if tested negative on 2 occasions and if an alternative diagnosis has been made. The criteria for discharge of a confirmed case, clinically stable, Nipah PCR from all 3 samples, as throat, urine, and blood, should be reported negative on 2 occasions at least 5 days apart. Now, coming to the sample collection, we know that whenever we are dealing with a suspect case, also suspect case name Nipah positive and the pole number personal protective equipments actually use here. Okay. Allade means Nipah confirm cheyda shesham matrame will use N95 mask, will use PP and so if for a suspect also we need to rule out Nipah virus infection because we are dealing with a disease with a mortality more than 80%. So the scope of making a mistake should be less than 0. So suspect should also be considered as Nipah positive till the reports come otherwise. Okay. So the sample collection, we are sending the RT-PCR should be collected as early as possible. So the sample should be throat swab in viral transport medium, 10 ml of urine in universal sterile container, blood 5 ml, CS of at least 1 ml if it is being taken. Sample collection should be done only after admission and appropriately secure isolation facility and ensuring that the staff member during the collection is using adequate PPE. നമ്മൾ ഒരാളുടെ സാമ്പിൾ എടുക്കുമ്പോൾ തന്നെ അയാൾ സസ്പെക്ട് ആയിട്ട് മാറിക്കഴിഞ്ഞല്ലോ. അപ്പൊ എന്തായാലും ഒ പിയിൽ വെച്ചോ അല്ലെങ്കിൽ ട്രയാജ് വെച്ചോ സാമ്പിൾ എടുക്കുന്ന ഒരു സിറ്റുവേഷൻ നേരത്തെ നിലവിലില്ലായിരുന്നു. സോ ഐഡിയലി someone is coming to the triage, you are means cross checking with the areas from where he is coming. He is coming from a containment zone or there is an epidemiological link. You are isolating the patient, and then from the isolation ward you take the sample, and the PPE definitely go for N95 mask, the double gloves, gowns, goggles, foot cover, etc. So donning and doffing in there, the videos the only thing that what I tell my residents is that COVID has done one big damage. COVID PP kit real donning and doffing the steps really maranuvoi. So regarding Nipah, when you are taking care of a confirmed case and all, the chance or error has to be 0, especially during doffing. You need to be very, very careful. So I request all of you, donning and doffing അറിയാമെങ്കിലും നമ്മുടെ training videos ഉണ്ട്. ഇപ്പം Trivandrum State Peds Cellന്റെ training video കണ്ട് how to don and doff properly. അതൊക്കെ revision എന്ന രീതിയിൽ you have to see. Okay, and also pay importance to your hand hygiene as well. So the IPC advisory and all, probably I'm not going into the depth of all these things. The importance of hand hygiene, use of PPE, use of disposable items and all. Only thing I would like to say, ഒരു കൺഫേംഡ് കേസ് ആയി കഴിഞ്ഞു കഴിഞ്ഞാൽ വി വിൽ അഡോപ്റ്റ് ഓൾ ദീസ് തിങ്സ് അല്ലേ. നമ്മൾ എന്തായാലും ഒന്നും കൂടെ പഠിക്കും, ഡോണിങ് ആൻഡ് ഡോഫിംഗിന്റെ സ്റ്റെപ്സ് പഠിക്കും. പ്രോബ്ലി ദർ വിൽ ബി എ ബഡി ടു അസിസ്റ്റ് യു ഇൻ ഡോഫിംഗ് ആൻഡ് ഓൾ ദോസ് തിങ്സ്. അത് ഒരു കേസ് ഐഡന്റിഫൈ ചെയ്ത ശേഷമാണ്. ഇപ്പോഴാണെങ്കിൽ എല്ലാവരും കെയർഫുൾ ആയിട്ടുണ്ട്. ഇപ്പൊ ഒരു നെക്സ്റ്റ് 1.5 monthsലേക്കും everyone will be very careful with infection prevention and control practices, the disposal of the waste and all those things will be very, very careful. But after that, പതുക്കെ ഇതെല്ലാം അങ്ങ് മറന്നുപോയി. പിന്നെ അടുത്ത നിപ്പ കേസ് വരുന്നവരെ പിന്നെയും നമ്മളുടെ മാസ്കിങ് പോകും, നമ്മളുടെ ഹാൻഡ് ഹൈജീൻ, 5 moments of hand hygiene ഒക്കെ പോകും. സോ ദിസ് ഷുഡ് ബി പാർട്ട് ഓഫ് അവർ കൾച്ചർ. ഈ പറഞ്ഞ നേരത്തെ ഇനിഷ്യൽ സ്റ്റഡി പറഞ്ഞ പോലെ തന്നെ ദ ചാൻസ് ഓഫ് സ്പിൽ ഓവർ ഫ്രം ദ ബാറ്റ്സ് ടു the humans can occur during any season എന്നാണ് ആക്ച്വലി ആ സ്ലൈഡ് കാണിച്ചത്. നമ്മൾ ഈ പറഞ്ഞ ഡിസംബർ ടു മെയ് മാത്രമല്ല. So can occur during any season, and actually the virus has been isolated from the Pteropus bats from 10 states in India and 1 union territory. So the discussions are there why the 3 outbreaks in Kerala occurred in the area around Calicut എന്ന് പറഞ്ഞു. പക്ഷേ കേരളത്തിലുള്ള എല്ലാ ബാറ്റ്സിന്നും, സോ എല്ലാ ബാറ്റ്സ് മീൻസ് ടെറോപ്പസ് ബാറ്റ് തന്നെയാണ് എല്ലായിടത്തും ഉള്ളത്. ഇന്ത്യയിൽ 10 സ്റ്റേറ്റിൽ നിന്ന് യൂണിയൻ ടെറിട്ടറിയിൽ നിന്ന് ഐഡന്റിഫൈ ചെയ്തിട്ടുണ്ടെങ്കിൽ ബാക്കിയുള്ള സ്ഥലങ്ങളിലും ഈ ബാറ്റ് തന്നെയാണ് ആക്ച്വലി ഉള്ളത്. സോ any patient with severe pneumonia, encephalitis, etc., or for that matter, when taking care of any patient we have to stick on to standard precaution. So standard precaution at the masking the hand hygiene infected secretion contact bare hands we very well know that. That is just standard precautions. These standard precautions madi really നമുക്ക് നിപ്പ വരുന്നതെന്ന് പ്രിവെന്റ് ചെയ്യാൻ. അല്ലാതെ PP kit ഒക്കെ കൺഫേംഡ് കേസിനെ കാണാൻ വേണ്ടി വേണം. അത് പ്രാക്ടിക്കലി എല്ലാ പേഷ്യന്റ് എടുത്ത് പോകുമ്പോൾ നമുക്ക് പറ്റത്തില്ല. കൺഫേംഡ് നിപ്പയുടെ അടുത്ത് പോകാനും സസ്പെക്ട് കേസിന് അടുത്തും പറ്റും. വാട്ട് ഐ എം talking about is when there is no outbreak also, we should never get should be caught with our pants down in a situation varan paadilla. So standard precautions means that whenever we are seeing any patient, there has to be the mask. Whenever we are seeing any patient, there has to be strict adherence to the hand hygiene as well. This can protect us against any infection. The steps of donning and doffing and all, you go through the video, revise once. Okay. പിന്നെ നമ്മൾ ഏതെങ്കിലും പേഷ്യന്റിനെ കാണാൻ പോകുമ്പോഴും you are not really confident about this, seek the help of your trained link nurses. So what I advise is that each institution should have some sort of a revision module. ഇതെല്ലാം നമ്മൾ ചെയ്തിട്ടുള്ള കാര്യങ്ങളാണ്. ആ വീഡിയോ നമ്മുടെ സ്റ്റേറ്റിന്റെ ട്രെയിനിങ് വീഡിയോ വെച്ചിട്ട് തന്നെ ഡോണിങ് ആൻഡ് ഡോഫിങ്ങിന്റെ വീഡിയോ ഉണ്ട്. അത് വെച്ചിട്ട് തന്നെ എല്ലാവരും ഒന്ന് നോക്കുക. അല്ല എടുത്ത് ചാടി കയറി പോസിറ്റീവ് പേഷ്യന്റിനെ കാണാൻ വേണ്ടി പോകരുത്. And we know that doffing is much more important than donning. So you know that most provider exposures occur during PPE removal. This is something we need to keep in mind. So between donning and doffing is more important than donning. But donning, നമ്മൾ പലപ്പോഴും ചെയ്യുന്ന donning വളരെ ശ്രദ്ധിച്ചങ്ങ് ചെയ്യും. പേഷ്യന്റിനെ കാണാൻ പോകുന്നതല്ലേ. എന്റെ തിരിച്ചു വന്നിട്ട് എല്ലാം കൂടെ ഊരി കളയുന്ന ഒരു സിറ്റുവേഷൻ, that should not happen. കാരണം we have to assume that the outer surface for the gown is infected. So donning വളരെ careful ആയിരിക്കും. But ideally, when you are dealing with a BSL-4 pathogen like Nipah and all, I will definitely advise a buddy system. Buddy system means that in the doffing room, there will be another person who is a trained person. Usually an infection control nurse or someone like that should be there, or a trained person should be there with a checklist. ആ ചെക്ക്ലിസ്റ്റ് നോക്കി മാത്രമേ ഡോഫ് ചെയ്യാവൂ. ഓക്കെ, അതായത് ഒരു മിസ്റ്റേക്ക് പോലും നമ്മൾ ടോളറേറ്റ് ചെയ്യാൻ പറ്റില്ല. വി ഡോണ്ട് വാണ്ട് എനി ഹെൽത്ത് കെയർ വർക്കർ ടു ഗെറ്റ് ഇൻഫെക്റ്റഡ്. ഓക്കെ, സോ അതുകൊണ്ട് നമ്മൾ ചെയ്യേണ്ടത് ഡോണിങ്ങിന്റെ റൂമിന്റെ അകത്ത്. സോ യു നോ ദാറ്റ് ദർ ഈസ് എ സെപ്പറേറ്റ് റൂം ഫോർ ഡോണിങ്, സെപ്പറേറ്റ് റൂം ഫോർ ഡോഫിംഗ്, റൈറ്റ്? So donning room, there has to be a checklist. Based on the checklist, you do the donning. Avade buddy onnu venda. But for the doffing, ideally there should be someone to observe you, to prevent you from making any mistake. Okay, so there has to be a checklist and there has to be a buddy ideally. So this is what I have been talking about, the buddy system. Okay, buddy system is there is someone to help you during doffing. Help you means, they will read out the checklist and all those things to ensure that there is no exposure, healthcare worker exposure occurring during the doffing procedure. So regarding this, prevention is better than cure, especially when something has no cure like Nipah. So our guidelines look very beautiful, right? There is algorithm like when should we be using monoclonal antibody, remdesivir, favipiravir, etc. But mind you, these drugs, remdesivir, favipiravir, etc., have never been tried in human patients for Nipah virus infection. In vitro studies are effectiveness. So the most important thing is that to prevent ourselves from getting infected. So I know that this session has been organized in connection with the Calicut outbreak. But നമ്മൾ മൈൻഡിൽ കൊണ്ട് നടക്കേണ്ടത് these sort of spillover events can occur at any point of time in the future also, and we should not get exposed without a mask or a proper hand hygiene, etc. So thank you very much for the opportunity. So the questions for the other districts probably is going to be this. What I also have, because I am in Trivandrum, a patient coming from a Calicut with respiratory symptoms, what will you do? So you should first of all you see whether there is an epidemiological link. That is, ഈ പറയുന്ന containment zone വല്ലതും ആണോ, അല്ലെങ്കിൽ ഈ പറഞ്ഞ കോൺടാക്ട് ലിസ്റ്റ് ഉള്ള ആരുടെയെങ്കിലും കോൺടാക്ട് ആണോ, like that. Okay, then probably you can isolate the patient and send for sampling. Okay, and we know that respiratory infection, the influenza is much more common than, or other circulating viruses like COVID, etc., is definitely much more common than Nipah. എല്ലാ ILAയും Nipah alla, but if there is, the patient is coming from a containment zone, has an epidemiological link, definitely you isolate the patient, send the sample. Okay, and we are also discussed when to discharge such patients, etc.